the Orthopaedics, hosted by Sam Dyer. Welcome to the Orthopaedics, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Hello, everybody. Welcome back to the Orthopaedics. My name's Chuck Dowell. I'm a PA practicing in orthopedics, primarily orthopedic urgent care. For this episode, we'll do a case presentation regarding something that I commonly see in the orthopedic urgent care. So for this case, I had a 52-year-old gentleman who walked in complaining of increased pain within the right biceps area. He states he was lifting a case of water into the back of his truck, and he immediately felt a pain within the right biceps, a pulling sensation, and what he described as a tearing sensation within this area. He looked over and noticed there was deformity within the biceps area. He made an appointment, saw his primary care physician the following day. His primary care physician diagnosed him with a proximal biceps tear and then sent him to our orthopedic urgent care to discuss possible fixation regarding this. I think this is a common injury that we see in the orthopedic urgent care and orthopedics as well. There's definitely an appearance of a Popeye deformity within the area that a lot of people find quite alarming. And I think for this reason, we get a lot of referrals for possible surgical fixation regarding this. So this is one of the reasons I chose this case. I thought it would be good to go over a brief overview and discussion regarding these proximal and distal biceps tears and what we typically think as far as treatments regarding these. So this was his dominant hand. It was his right side. He primarily did low impact activities, and for work, he primarily did computer activities. When I'm seeing somebody in the clinic and they come in complaining of an upper extremity type injury, one of the first things I always ask them is this their dominant side or non-dominant side? Then I ask them what they do for work. Are they a heavy laborer, or do they do more computer work type activities? And then I ask them what they do for fun, sports-related activities, because I think all these things do play a role into the discussion regarding possible fixation or not fixation, and we'll discuss that more in a little bit. On exam, he had an obvious Popeye deformity noted within the right biceps area. The Popeye deformity is the retraction of that long head of the proximal biceps down into the mid-biceps area. This is slightly different than the reverse Popeye deformity you'll see with distal biceps tears. I think one of the first things I do when examining a patient, especially for an upper extremity and biceps, is I just have them lay both hands on their lap and I look at the contour of their biceps. And if you can't tell the contour of the biceps without them flexing, you can ask them to kind of isometrically flex and or flex their elbow against your hand to see if you can tell the contour of the biceps. If there's an obvious deformity within the contour, then you have to decide, is that deformity coming from the proximal aspect or the distal aspect? Proximally, there's not a lot of special tests to evaluate this. You can palpate the proximal bicipital groove, and usually that will be palpably empty. You can see the deformity within the area. And then with the elbow flexed at 90 degrees, you can have the patient supinate and pronate to see if there's any change within this deformity, as the biceps is primarily a supinator muscle. Again, with the distal biceps tears, when I do see these in clinic, the mechanism of injury is typically a very similar mechanism. They have some type of eccentric and or concentric force against the biceps where they're trying to lift something heavy or hold something, and their elbow gets pulled into extension and they feel a tearing sensation. The distal biceps ruptures typically have a lot more ecchymosis and edema within the antecubital fossa area. One of the common tests they describe regarding the distal biceps tears is a hook test. I found this to be a little unpredictable because oftentimes the patient will have significant swelling noted within the antecubital fossa area, and it's difficult to tell whether you can feel and or palpate that biceps. Sometimes you can palpate it. Remember, it does sit a bit medially within that antecubital fossa. Sometimes you can't. If you can palpate it, oftentimes there'll be a partial tear within the area, and or there'll be some fibrous underlying tissues of the underlying brachialis tendon, and this can be misinterpreted as a possible intact biceps. What I found to be the most accurate for distal biceps rupture is just having the patient's elbow flexed at 90 degrees. And again, looking at that distal contour of the biceps and having them supinate and pronate. With supination, it should pull that biceps down as that radial head turns, and the contour should be lost. And as they pronate, you should be able to see that contour much more significant. So oftentimes, if you do this bilaterally, you can see that distally within the biceps, there's a difference within the contour, and that can help you to make the diagnosis. Obviously, if you're unsure of the diagnosis secondary to the swelling, you can get an MRI for the distal biceps tears to confirm whether it's a high-grade partial tear or complete tear of the biceps. Oftentimes, we think if there's more than 50% of the tendon torn, this could go on to possible full tear of the tendon, and a lot of times we'll end up repairing this for the distal biceps. If there's less than 50% of the tendon torn, we could potentially brace the patient and allow this to heal, but there is a possible high risk of re-rupture rate within the area. So regarding the proximal biceps tears, one of the biggest concerns that people have is, hey, that biceps is my main elbow flexor. Am I going to lose a significant amount of elbow flexion? And the answer is no. The biceps brachii is not your main elbow flexor. The brachialis is actually the main elbow flexing muscle. So that actually sits under the biceps. The biceps primarily does elbow flexion, but supination is its main activity. So some people will have about 10 to 15% loss of elbow flexion, but they will also have some loss of supination, which is what the biceps brachii primarily does. So when I'm having a discussion with the patient regarding surgical or non-surgical treatment for these proximal biceps tears, the number one thing I discuss is you'll have a possible cosmetic deformity noted within the area. If they don't like this cosmetic deformity, then that could be a reason to fix these proximal biceps tears. If they're not worried about the cosmetic deformity, then I discuss the possibility of having weakness. Usually they're going to have some significant weakness initially, so about 30% weakness with acute elbow flexion, but typically don't have any weakness with chronic elbow flexion. The studies regarding this are a little bit all over the board. Some studies say 5% weakness with elbow flexion. Some studies go up to approximately 20% weakness with chronic elbow flexion. Most of them do document, though, that there is some component of 20 to 50% weakness with supination activities, especially with fatigable supination activities. So if your patient is a carpenter or does a lot of rotary activities with their wrist, they may notice some fatigue, especially when trying to screw a lot of screws in and or that last screw to really tighten things down. They may notice some weakness with supination of that forearm. If that's going to significantly affect them, then you could send them to the surgeon to have this possibly repaired. One thing to counsel the patients on is that a lot of patients do get fairly significant spasming within the biceps area. So the long head of the biceps that goes up and attaches into that superior glenoid, that's the part of the biceps that typically tears 90+% of the time. The short head of the biceps really only tears approximately 1 to 3% of the time, and the distal biceps that other 5 to 7% of the time. That long head of the biceps will retract down. It will scar down into that medial head or short head of the biceps, but during that scarring process, they'll often have 3 to 4 weeks of fairly significant spasming within the area. Again, they'll have acute weakness with elbow flexion as well. If they are going to have this repaired, it's not something that has to necessarily be done acutely. We can do this repair later on down the road. Typically, we want to get this done within 3 to 4 weeks because the more that biceps retracts, the harder it is to find that proximal biceps and have that repaired. Similarly, with distal biceps repairs, these are something that we do want to do acutely within 2 to 3 weeks because, again, if it retracts proximally, sometimes it's hard for it to be pulled back down into position, and the post-surgical rehab can be a lot more difficult. If we choose not to repair these distal biceps, they will have fairly significant weakness. And again, most of the documented literature is a bit all over the board, but with non-operative treatment, they do stay approximately 30 to 50% weakness with supination activities and approximately 20 to 40% weakness with flexion activities if you choose not to repair the distal biceps. So again, you typically put these patients in a sling. I'll counsel them regarding the possible deformity. I'll let them know that that bump is going to remain there and that bump won't necessarily improve and or get better. So they'll always have this Popeye deformity. Within 6 weeks, we can allow them to return and or go back into most of their weightlifting type activities as they start to feel better. If they choose to have it repaired, again, we can have them referred to get the biceps tenodesis performed. One of the incidental things, and especially in this patient that I have noticed in the past, is that this patient had anterior shoulder pain for quite a while when doing certain activities. He chose to have his proximal biceps tear fixed non-operatively, his anterior shoulder pain completely resolved. And so if you remember, a lot of the times patients that have anterior shoulder pain, it could be coming from some partial tearing or some tendonitis within this proximal biceps area. One of our ways to surgically correct that is to do a biceps tenotomy, where surgically, arthroscopically, we go in and we actually cut the long head of the biceps. That'll often cause this Popeye deformity. The patients will have similar symptoms to what this patient had with an acute tear. And oftentimes, if we have the availability, we'll do a biceps tenodesis and not a tenotomy. The tenotomy is where we release the biceps tendon, and they'll have this similar Popeye deformity. The tenodesis done arthroscopically or open, where we can tack the biceps back down distal to the bicipital groove into the proximal humerus area, and then they won't have these functional deficits. This patient went on to do quite well. We put him in a sling for immobilization for approximately 7 to 10 days, allowed active assistive and progressive passive range of motion activities. At 6 weeks, he basically returned back to all normal activities. And for him, he had no functional loss. He was able to return to all of his sports without any incident or concerns. So I thought this would be a good review on these proximal biceps tears. These are often hard to discuss with the patient because oftentimes they say, look at this obvious deformity with my biceps. Are you sure we shouldn't do something about this? I found that if we have an educated discussion with the patient, we discuss the risk benefits of the surgical fixation, including the scar that's going to come within the anterior armpit type area, possible risk of infection, and the possible improvements that they'll get from the cosmetic deformity and functional aspect. Most patients do choose to treat this non-operatively. Thank you for listening. I appreciate your time. I hope to come back and discuss more frequent cases and or interesting cases that I do see in the orthopedic urgent care.
Thanks again for listening, listeners. The Ortho Bootcamp is coming soon to Charlotte this November. Sign up today.